All right. Okay. Good morning, everyone. So today we're going to be talking about the Cooperative Extension National Framework for Health Equity and Well-Being, and specifically looking at where aging fits in that model. So mostly I'll be looking at the model and describing that and sort of walking our way through it. But throughout that, I'll be sprinkling in some concepts related to aging and thoughts related to how we can implement aging into our extension work. So I'm Dr. Erin Yellen from Kansas State University. I currently am the interim director of the Center on Aging, but also am the Adult Development and Aging Extension Specialist. I was privileged to be a part of the group that helped to write the national framework. So I'm excited that we can continue to talk about the work that we did as a really stellar group. And so I'm excited to share that with you today. Okay, so the roadmap of what I will be talking about is really quick: where we've been, the updated model, how aging fits, and what we can do. So where we've been. So some of the key aspects of the model that have been developed for extension programming is what we'll be talking about. But first, I want to provide the context of sort of how we've gotten to where we are today. So if you remember or were around at the time, in 2014, Cooperative Extension leaders published a national framework for health and wellness. So this is what sort of preempted the model that I'll be talking about today. So within that, the goals were to guide community health programming and establish extension as a key player in community health. So prior to 2014, extension provided a lot of health and nutrition programming for decades. We certainly weren't new to the arena of health and wellness, but we needed to improve. So at that time, we collectively really lacked a strategic focus nationally that our other peer organizations had. So we wanted to bring our partners' attention to the strengths that extension has, but then also work our way through identifying strategically where we could go in the arena of health and wellness. So in the middle there, you see that life happened in between 2014 and then 2020, and when we were releasing this in 2021, 2022. So it became clear that the time was ripe for a strategic and thoughtful re-envisioning of extension's role in community health. So in 2020, ECOP, or the Extension Committee on Organization and Policy, pulled together a group called the Health Innovation Task Force. And one of those charges were to have a group revisit the national framework and update it. So a subcommittee was assembled to review and revise the framework. And it was such a great learning experience and really a great opportunity to dig into what extension can be doing in this arena. So looking back at 2014, just to take a little glimpse at where we've been, the main goal was to spark initiative within extension to do for health what extension had done for agriculture in the past century. So the model was centered, as you can see in the purple there, around increasing the number of Americans who are healthy at every stage of life. And it tried to lay some groundwork for how we could organize ourselves around this desired outcome. So as an aside, when I very first saw this model, I immediately felt that little pit in my stomach because it featured an older adult who was hunched over and with a cane. So that's sort of a great preface for our discussion on ageism coming up. So as a result of this model, many states began to use this to help guide their work, perhaps influence who they were hiring, and start to think about their future. So nationally, this gave Extension a platform to connect with and receive funding from various organizations, including the CDC and USDA. So really, Extension, because of this model and the work that it was inspiring, became a lot more prevalent and people started to see us is on a more national level. However, the model admittedly had numerous shortcomings. So for one, the model primarily focused on providing direct education that Extension is historically known for. We know that this can make small impacts, but we also know that education is only really a drop in the bucket of what is needed to truly improve health. So one thing that I've shared before is that we can repeatedly tell people to eat salads and exercise, right? But if they don't have the access to fresh and healthy food to make that salad or a safe space to be active and get that physical activity, then really what are we accomplishing by telling them to eat salads and exercise? And I also believe that there could be some unintended consequences of our work. So when we tell individuals to eat healthy, eat salads, be active, through these educational efforts, could that potentially be damaging to one's psychological well-being, for example? So by telling them that they need to eat healthy and be active, when they don't have those resources, could that cause feelings of failure or despair or even hopelessness? So they know that they want to do these things, but they may simply not have the access to do so. So this is sort of an oversimplified example, but hopefully it can help us all think a little deeper about the impacts that we are providing through education and how we might be able to do a little bit more. So we have the capacity really to do more, and we need to do more if we truly want to improve health and well-being across the country. And so that's going to require that Extension takes a step back and begins to think about those big, wicked, complicated, and uncomfortable issues. So what are those issues? And we'll get into that when we're looking at the new model as well. But just as a teaser here, those are those root inequities that protect or limit your potential to thrive. So that's diversity, equity, inclusion, social justice, racism, ageism, and those other injustices and inequities that really can build the true cornerstone to health and well-being. So if Extension chooses to not really truly address those inequities through action, we're never going to achieve that goal of what Extension did for agriculture and doing that same thing for health in this century. So in order to keep moving the system forward, there was consensus among the group that we wanted this framework to both represent our historical growth, but also to provide our system guidance for the next 5 to 7 years. So in order to be relevant and effective, we looked at the need to utilize contemporary best practices that move beyond the traditional Extension model of direct education on health behaviors and truly begin to address those contextual factors that can influence health. These contemporary best practices can include that policy systems and environmental change concept that we've been talking a lot more about within Extension, and then also the work needed to address the social determinants of health, another concept that we've been talking a lot more about within Extension. So we know these terms, we talk about them, but it can be pretty difficult for Extension professionals to follow through on these in effective and meaningful ways because it's scary. We haven't done this before. Perhaps we don't have strong examples to follow. I know I'm one of those people where I love a good example and then I sort of can build my ideas off of that. And so sometimes it's hard. We don't know exactly what that looks like. So we also wanted to create a strong urgency for this work. So university systems and Extension, we know these are slow moving ships, but we don't have the time to wait for the ship to pivot. It can take forever. And there's typically always a faster route, but we just need to really be creative and bold enough to find that route and execute. So we need to value and promote being proactive in meaningful ways rather than just being stuck on the ship behind the times and always rushing to be reactive. So in the aging realm, we know that the baby boomers are rocking our world and are going to continue to rock our world, but we can't wait until the last of them turn 65 to finally do something about providing older adults the best opportunity we can to age well and live vibrantly through the end of their life. That's that being reactive component. How can we be proactive in building environments that are going to help people live as healthfully as they can throughout their entire lifespan? So last, we wanted the model to really prioritize lifelong health and well-being for all people, not just the white, easily reachable audiences that many extension professionals have worked with for years. And we certainly needed to expand beyond Americans, as was used, or the verbiage was used in the 2014 model as the audience for the targeted outcomes. So in the 2014 model, it said helping to improve Americans' health at every stage of life. But we know that using the term American can be pretty limited and excluding of others. So we needed to strive for inclusivity in everything we do, and we wanted to be mindful of that, including with our language, being lifelong learners ourselves, and then working alongside people who aren't like us. And we need to be doing these things even though they're uncomfortable. So often in my personal work as an adult development and aging specialist, I have anecdotally found that so much work related to aging has been focused on education, which is okay, but has primarily been delivered to older white women when we look at our evaluation data. So personally, I have worked with others to develop a lot of really great curricula related to aging. And I can certainly make the argument that all of it has a space within extension. But there are some examples within those educational initiatives where we can make bigger differences and generate those broader impacts. So one of my examples with this is one of our fan favorite programs that's called Gray for a Day. And that's a sensory aging experience where you have materials and you get all decked out into sort of this aging experience where you're simulating some age-related sensory decline, or the potential age-related sensory declines that some individuals might face. So one of my favorite utilizations of this program, from what I've heard and experienced from agents out in the field, is when it's presented in and then even passed on to family and consumer sciences and science educators within K through 12 schools. So although it seems like this cute program where we get dressed up and wear glasses and gloves and be silly, it's really having great impacts in teaching younger adults to learn about and develop a greater understanding of how they can better interact with older adults, but also how they can work to age healthfully across their entire lifespan. This program has also sparked the expansion of creating intergenerational learning groups, having kiddos and 4-H kiddos do community service projects with older adults. And then one of my favorites too is training students to work with older adults to better understand and use technology so they can keep connected with their families. So that connectivity can have such a big impact, because we know that combating loneliness, depression, anxiety, and are fantastic things that can prolong life expectancy through reducing those negative emotional outcomes. And by teaching older adults how to use technology to stay better connected with their families, we're reducing that risk and increasing the likelihood that they're going to live a longer and healthier life. So that's just a quick example of how we can use programming and build upon it to do these bigger things and have these bigger impacts. So we can transform traditional extension education. It still has a place, we can still do great things with it, but we also need to continue to build upon that. So I wanted to transition to a couple of the big themes that were in the model that sort of relate back to those bigger ideas and bigger things that we should be figuring out how to do. And that's within health equity, which obviously is in the title of the new-ish model, and health disparities. So first is health equity, which can be defined in so many different ways by different people, different organizations, different research articles, but essentially it all boils down to the idea that we're giving people the opportunity to be healthy, and that should be freely available to everyone, regardless of their circumstance, the condition, social condition, economic condition, or any other unfair, preventable difference. So as you begin to think about the work that you could be doing in extension, I ask you to think about what inequities people are facing. So in my world and working in aging, I obviously work to think about those inequities that older adults face. And then further, what inequities people face across their entire lifespan that can impact their ability to age well. So thinking a bit more in depth about equity in older adults, and just having some time to have some deep thought into that can be really valuable. And that second concept or second big idea are health disparities. So fundamentally, looking at health equity, that's more of a moral and ethical commitment to eliminating health disparities. And health disparities are how we measure progress towards achieving health equity. So health disparities are defined as avoidable systematic health differences that adversely affect economically or socially disadvantaged groups. So historically marginalized and disadvantaged social groups are reflective of multiple identities that can include race, ethnicity, religion, geography and where you live, ability, gender, sexual orientation, income, and of course, age. So to break it down into a super simple manner, disparities are those differences, while inequities refer to the unfairness and injustice. And within both of those concepts lives ageism and so many other isms and concepts as well. But of course, we're going to be talking about age and ageism today. So ageism is a critical component of those disparities and inequities that older adults face in the scope of well-being and lifelong health. So it's defined as prejudice or discrimination on the grounds of a person's age. So of note, this can happen to both younger and older adults. So obviously I'm going to be focusing on the latter end of the lifespan, but ageism can happen really to anyone. And we see this to be particularly true with young adults, millennials, and those sorts of younger generations. So looking at a little bit deeper, the World Health Organization says that ageism is prevalent, unrecognized, unchallenged, and has far-reaching consequences for our economies and societies. So it has a really big impact. It's a really big deal. And it's firmly embedded across the entire world. I've had the opportunity to work with folks in other countries, and I'm constantly surprised at how ageism sort of is sprinkled throughout the world, because so many times I think we live in the our United States bubble, but it's not just us. It's everywhere, and can be really prevalent in other places. Of course, not everywhere, and we know that there's cultural and familial differences, but it is widespread. So looking a little bit deeper into ageism, it's really amazing the consequences that it can have on health and well-being. So looking at older adults, ageism is associated with poorer physical and mental health, increased social isolation and loneliness, greater financial insecurity, decreased quality of life, and premature death. And an estimated 6.3 million cases of depression globally are estimated to be attributable to ageism. So all of that intersects and exacerbates other forms of bias and disadvantage, including those related to sex, race, and disability, all leading to these incredibly negative impacts on people's health and well-being, or those potential negative impacts. Okay, so digging a little bit deeper into that, we wanted the framework to come out and really clearly reflect that ageism and the other isms are not only about prejudices that are held by individuals, but that ageism is embedded in our economic system and in societal norms, that it's produced and reproduced at every level of government. And our history as a nation also provides a foundation that we really value youth and youthfulness. And that allows ageism really to continue to flourish. And we know that that can ultimately inform how healthy one person is or how long they live. And it's not possible for us just to educate our way into health equity. It's widely known that research shows ageism is associated with those poor health outcomes that I've discussed before and negatively influences overall healthy living. And these are, again, exacerbated when we're considering intersectionality. So those combinations of discrimination and stereotypes and those root causes of structural inequity, such as racism, homophobia, et cetera. And we'll talk about those on the next slide. So the new framework really looks at those more complex issues rather than just individual choices, eating salads, and working out. So how does the model support those inequities? And what does it recommend we do about it? So here is the visual of the new framework. It's a lovely little fish, but it represents the changes in how we're organizing ourselves around health programming and orienting our work as extension professionals. So if you look on the very outside there in that outer ring, we see those root causes or those structural inequities. And we can see that includes ableism, ageism, xenophobia, racism, homophobia, classism, sexism, and we can continue to build that list. But within that, in that next ring, we see norms, policies, and practices that really are a result of those structural inequities, and they feed off of those structural inequities. And those norms, policies, and practices, of course, then they all inform that next ring, which are those social determinants of health. So we were really purposeful in identifying what the social determinants of health are, really those categories of the social determinants. So depending on where you look or the different models or different organizations, you're going to see anywhere from 5 to 7 to 9 social determinants of health. But we wanted to expand the social determinants of health into unique categories that Extension is really working in, or that we're really good at, or that historically we've been working in. So access to healthy food. I mean, obviously, this is a strong connection between SNAP Ed and SNP, supportive infrastructure, social environment, employment, physical environment, health systems and services, public safety, education, income and wealth, and housing. So one of those things, oftentimes access to healthy food isn't broken out specifically within social determinants of health, but because of Extension's huge relationship with that and history working in that area, we wanted to pull that out. So the next ring is where you'll find cooperative extension. So we're inside that ring, we're trying to have an influence on each of those outer rings. So at first, like these rings are sort of working in, and now we want to take that cooperative extension ring and work it out. So how are we doing that? What do we want to do? We want to create healthy communities through collective action, identify and address health inequities, and promote healthy behaviors through communication and education. And that's really where that historical context of extension engagement sits. So within that, you can see that at the end of the day, our big goal is that focus on health equity and improving population health and achieving equity in health status. So we wanted to produce recommendations on ultimately how we can do this as a system. And that includes the 5 values and ideas on the tail of the fish on that far left-hand side. So I'm going to walk through those 5 recommendations, talk about them a little bit more in depth, but also talk a little bit about aging. So these concepts aren't all related directly to aging, but aging fits within all of them. So what can we do? The first high-level recommendation is to establish health equity as a core system-wide value by prioritizing hiring, retention, and development of a diverse and culturally competent workforce. And that includes both recruiting and retaining older adults as employees, but also volunteers. We know volunteers have a huge presence within Extension. And also hiring people that present core values on inclusion, of which aging is a component, of course. We should also consider creating equity action plans that contain accountability mechanisms and then communicate strategies for achieving those health equity goals. So within all of these strategies, age must continue to be a significant factor. So again, hiring older adults, retaining older adults in the workforce, they do have value. And we shouldn't oust workers just because they're quote unquote old or dead weight. So we need to find the value of a strong and diverse workforce and groups of volunteers as well. The next one, we can also work to implement this framework by using community assessment practices that integrate data science and resident voice. So for example, establishing and expanding data sharing agreements to gain access to demographic and health outcome information so that we can accurately apply resources and develop programs that really are intended to make a difference in the issues where difference needs to be made. So implementing this can also look like intentionally discussing social determinants of health within Extension materials. So how do we take the traditional Extension programming and build it out into addressing those social determinants, into addressing those structural inequities, sort of how I mentioned with Gray for a Day, and how we're essentially trying to train up the next generation to be more comfortable interacting with and working for older adults. How can we encourage this generation to realize that they're going to be working with older adults? How can we get them engaged in the health professions and services and helping professions? So in the context of aging, we can also assess those aging-related challenges with the input of older adults themselves. So this will help Extension to more accurately focus and distribute resources and develop the necessary programs that we need to develop, while avoiding the assumptions of what we presume the issues of older adults are or what their challenges are. So we can't make those decisions alone. We need to be working with older adults themselves and saying, hey, like, what are your challenges? What are the opportunities? Also incorporating data within that. But there's so much more that we should be including within our initiatives and when we're designing our initiatives, rather than just sitting back and using this traditional expert model of this is what's wrong. So we can continue to take those concepts, and I encourage you to consider keeping that aging lens through that. So how do our environments promote or inhibit lifelong health and well-being? So the next one is to invest in the success and visibility of Extension's health-related professionals, programs, and initiatives. So essentially, this is increasing the number of health positions or health-related positions in as many states as possible and providing really strong professional development on the core concepts of health extension. So some topics could and should include best practices for working with older adults, but also appropriate and responsible use of data, really understanding how to pull out community health data and how to use that. Strategies for engaging resident voice. So how do we get older adults included when we're trying to really make a difference in the lives of older adults? How do we include their voice? how do we really think about the power of bias? How do we think about those social determinants? How do we think about Extension's role in addressing them? How do we build coalitions? How do we engage in translational science tools and proficiencies? There's so much that we can be doing by investing in the success and visibility of our professionals, programs, and initiatives. And one thing I mentioned about professional development on the core concepts of health extension, soon this month, we're going to be releasing a pilot, but only within Kansas. It's a micro-credential opportunity on working with older adults in cooperative extension. So this March through May, we're going to be doing this pilot, but after that, and then doing some refining, we're hoping to open that micro-credential opportunity nationwide for extension professionals to engage in and learn more of the basics of how do we appropriately work with older adults. And then we have a lot of elective modules where you can learn more about specific topics. So we're excited to be building that, and we'll be sharing more about that in the near future. So the next one, just as the previous 2014 model suggested, we need to be establishing and strengthening partnerships with academic medical centers and various health science colleges or units, such as public health, nursing, pharmacy, vet med even, dentistry, social work, and of course, geriatrics. The framework encourages relationships between institutions to share expertise, to leverage limited resources, and build multi-state strategies. There's really so much opportunity in working with others. I've learned during my time at K-State and recently in developing some more strategic initiatives around aging, the true and strong connection between vet med and human health as well. I recently went in and I worked with our physician assistant program during their geriatrics component of their education. I was talking with them more about the social side of gerontology. It's really fascinating to me how many people are in the health-related professions or are studying health-related fields, but they don't get any concept of the social side of actually working with people. There's a little bit more being sprinkled into that than there was in the past, but it's really limited. So we're teaching them how to treat people, but not how to actually engage and treat people with kindness and respect and avoiding ageist practices within the medical field. So thinking a little bit deeper back into the extension realm, it's not uncommon for states to have limited people power, specifically when it comes down to aging. So I know I'm one of very few adult development and aging state specialists within the cooperative extension system. We do have a few agents who are dedicated to that area specifically. We also have others who are in family and community wellness or health-related extension educators, but they have a particular interest in aging or a focus in aging, or their boards or program development committees really want them to be working in that area, but they're not solely dedicated to working with older adults. So we really do have limited people power. So how do we do this work when we have that limited people power? So we can start by working with others. Seek out researchers, organizations, private businesses that are working within the aging realm. So this can kind of seem scary at first, but you don't need to have grand ideas or huge strategies or anything like that. Just simply reaching out, asking to come over to visit their space or just learn more about what they do is really a good thing to do. So maybe you don't end up working with them. Maybe it's like an aging related facility within your community that focuses on health and well-being, or like one of those facilities that works on helping people feel better about their bodies as they age. Just going in and talking with them, learning more about what's going on in the aging realm within your community can be really neat, even if it doesn't turn into anything. So within extension, it's also critical that we draw upon the expertise that we have across the country. So establishing relationships with others, pulling programs and ideas from others, stealing ideas. That's what extension is really all about. Like, we're not supposed to be, hiding away in our counties or in our states and not sharing things. Like, that's really is a core component of extension, to work with other people. Like, why should we be reinventing the wheel all the time, right? And the North Central Region Aging Network is a fantastic example of that. I'm really proud to be a part of this group that's really working to increase that people power, increase those resources, and help to reduce the reinvention of the wheel across the country. All right, 2 more slides, I believe. So the last high-level recommendation is utilizing a community development approach to advance the work of coalitions focused on influencing the social determinants of health. So this is really gathering those key players together in our local communities that can really strive to make a difference. So this can also include building a workforce that's comfortable stepping away from that expert model of program delivery to one where extension professionals are also engaging in their communities as equal partners. Extension does not always mean to lead the initiative. It's also okay if we're silent partners, if we're partners who are actually engaging in the work, if we're there to just learn more, to make sure that we're not duplicating effort, whatever it may be. But we need to be working together and sort of know what's going on in our communities, and not always being the leader and not always being the expert. So additionally, when we're looking at who we're hiring, we need to be creating position descriptions that attract individuals with expertise in particular areas. So I'm currently doing a research study that is looking at who we're hiring within extension. So we say we want to do all of this great not aging related, but health related work, and we want to be making a difference in social determinants and doing policy systems and environmental change. But are we actually hiring people who can do that work, or who have expertise in that work, or who has background in that work? So who are we bringing into our system? How do we build the capacity of our system? And of course, people can learn, and we can do trainings and professional development, but ultimately looking at what is the foundation of our system. And then, of course, we want to continue to build the capacity within our communities through those coalitions and those other volunteer programs, thinking about, the differences that master gardeners have made, or master food volunteers, looking at those volunteer organizations within Extension. How do we draw upon those to make a bigger difference? And then, of course, from that aging related lens, how do we continue to incorporate and value the input of older adults? And how do we try to keep a sense of aging related issues in all of the approaches that we're doing? So it doesn't always have to be an aging specific initiative, but we can typically almost always think about older adults within a lens of, we can use an aging related lens and apply it to what we're doing. For example, there's a lot of need for childcare. We know in rural Kansas, and that's not unique to us, there's a huge need for childcare all over the country, particularly within rural areas. But we also know there's a huge need for long-term care facilities. We know that there's space, and we need to develop the capacity for that. So there's space in that, in space and room for development of that. So how can we combine those two things? How can we take an aging related lens? How do we take an aging related need and apply it to developing childcare facilities? Intergenerational facilities exist, they're amazing, and they have beyond amazing outcomes for kids and older adults. So how can we take the resources that can be allocated to building and developing long-term care facilities or senior centers and combine those perhaps with funds that could be allocated to developing childcare centers? How do we combine those? Think about bigger impact. So we think little kids, then aging doesn't automatically come to mind. But what if it did? What if we started thinking bigger and in terms of intergenerational relationships, and started really keeping aging related issues in our minds when we're doing different initiatives. So always just remembering that change occurs in context and throughout the lifespan. So again, just because we're working on a particular issue that isn't directly including older adults, maybe it can, or maybe it should, or maybe there's some component that can benefit older adults or pave the way for healthy aging in your community. So last slide here is sort of asking the question of what we can do. I get this question a lot. You know, we have this big model. It is a lot. There's a lot of pages of words that you can read related to this model. You can look at this big fish model and work to decipher it and find your own place within it. But what are some action steps that you could take? So first, I encourage you to obviously take a deeper dive into that model. So I've breezed my way through it, given sort of an overview explanation of the model. I've attempted to throw in some ideas about how aging fits and how we can keep that lifespan context into what we're doing. But think about taking a deeper dive, reading and learning more about it, skimming it, even just, you know, taking a look at that model, and then thinking about how you can apply it to your own work. Next, of course, I challenge you to learn more about the disparities and inequities facing older adults in your community. So what are those bigger challenges that you can see and identify? What does the data support? What do older adults have to say about challenges and opportunities in your community? Get outside of your comfort zone, work to think about these bigger issues. It can be scary, it's new, it's different, but also thinking about how you can take that traditional extension related programming that we're so awesome at and that we're already doing, and how do we build upon that to make bigger impacts? How do we draw upon our expertise and our ability to engage within communities to create bigger change? Next, these are big ideas, so I'm not going to ask for answers right now because, you know, even I and one of those persons where I have to really think about it and mull it over and, you know, make some strategic decisions or come up with some bigger ideas. But I encourage you to think about one strategy you could implement to learn more about aging in the context of this model. Maybe it's thinking about what disparities do older adults face in my community. Maybe it's thinking about one social determinant of health that you're really passionate about and then trying to apply it to aging, such as access to healthy and nutritious foods. What does that look like in the context of older adults? Like, is Meals on Wheels in your community? Is it working? What about access to food pantries and community meals for older adults? Like, looking at that one concept of access to healthy foods within the social determinants of health, and then trying to see how it relates to aging. Maybe think, you know, is there an issue here and what potentially could we do about it? Who could we partner with? Maybe I just need to tell somebody that there's an issue and they're the ones who are going to be working on it. Remember, we're not always the experts. We're not the ones always doing the work. So thinking about some things that can spark some change in yourself, in your own work, maybe even within your office, within your bigger extension system in your state or your community, thinking about how we can work with our ag agents or 4-H agents or ag or natural resources or community development, thinking about those different realms within extension. How can we educate others on working with older adults? So thinking about those purposeful strategies. So again, I've sort of breezed over this big model of cooperative extension, health equity, well-being, sprinkled in a bit about how aging fits, encourage you to read more about the model and just learning about these bigger concepts a little bit more in depth, thinking about how aging fits. So I hope that you've learned a little bit, have some sparks to perhaps learn a bit more and do a bit more. I encourage you to hop on to the North Central Region Aging Network's website, learn more about what we're doing and the resources and programs that we have to offer, again, you're not on your own. We are hoping to provide a lot of things that we can share across states and to stop the reinvention of that wheel and really work to make a difference in the lives of older adults. So that is all I have for you today. I will stop the recording, but if anyone has questions or anything to share, then you're welcome to ask those, or you are free to go about and enjoy the rest of your day.